How's it
Hi,
going?
Ash.
Good.
Going
Miss you
great.
guys.
Going great. Miss you.
I know I feel like we haven't seen each other forever and it's only been a week.
I know. I don't.
Well,
It's only been for 5 days,
That's true.
but a
but
lot has happened.
what a weekend in Costa Rica, huh?
I
Yeah.
know.
We have I'm just letting a couple of other people join and then we'll get started.
Yeah, I wasn't sure if people could join on a Saturday afternoon, so I had some people send in some questions yesterday, just in case we need more topics.
Perfect.
Nice. Nice. Always prepared, Ashley. Always prepared.
I try.
Okay, I see Jolene Edgar just joined. Hi Jolene.
I love Jolene, always writing about the cutting edge things objectively.
That's right.
That's the key word.
It's been so interesting to me that there have been so many haters just commenting about these techniques when they really don't even understand them.
Right. So hopefully today we're going to demystify everything, not only for all of our patients and potential patients out there, but for all of the people who are joining for some educational content.
Yeah.
I think I can't wait to do this because there's so much that we're going to talk about and try to simplify things. And it's really not that complicated. And once we explain it, I think people are going to be on board. The haters are going to hate and the lovers are going to love, I guess.
All right. So why don't we just get started by introducing ourselves? I think everybody knows who we are, but we'll introduce ourselves and say where we are located.
All right, I'll go. I'm Dr. Ashley Gordon, a board certified plastic surgeon in Austin, Texas, and I've been in practice since 2007.
Hey guys, it's Steven Sigalove here in Scottsdale, Arizona. Actually, technically Paradise Valley, Arizona, which is where I live. I am a board certified plastic surgeon specializing in aesthetic and reconstructive breast surgery. I've been in practice since 2004, relocated my practice from Chicago in 2018, and am loving the Southwest.
And I am Troy Pittman, board certified plastic surgeon, and my home base is Washington, D.C., and I also have an office in New York City. So, you know, before we get to minimally invasive, I feel like we just had our 1 year anniversary from our last trip to Costa Rica when they opened up the world of Motiva to us. And now we're just a few months short of 1 year with Motiva.
Yep.
So how's it going?
It's going great. I mean, I feel like in my practice, what they've seen in the studies and in the literature is definitely very similar. Knock on wood, we haven't had any capsular contractures, we haven't had any malpositions, and I'm almost at 200 cases. So since last October, so I think the data always tells the truth, and I think what we're seeing is in line with that.
Yeah, I echo that. I jumped on board in October as soon as they became FDA approved, and I don't think I've used any other implants since. And the performance, the patient satisfaction, beautiful natural results are spectacular. And one of the things that I'm really excited about, not only the capsular contracture piece like Ashley spoke of, but also the rippling piece, which is even more important. And when you compare the rippling in very low BMI patients, I do a lot of surgery on very fit athletic patients out here in Scottsdale. And I am so pleased with the lack of rippling compared to some of the other silicone gel implants out there. So all in all, it's been absolutely awesome, and I expect it to nothing but get better and better.
And Steve, you were really one of the early adopters of this pre-pectoral breast augmentation, which kind of was a extension of pre-pectoral breast reconstruction. But now that you have the Motiva implants, do you feel like that has really changed that operation for you?
I think it makes it a lot more predictable, and I think that using the whole preservation idea that we're going to talk about later, minimal dissection, minimal disrupting of the tissues, it really allows the implant to do the majority of the work. And I have to do a lot less dissection, traumatizing the tissues, and patients just simply do better after surgery. These implants with, both the ergonomics and the round styles really gives patients an option to have virtually any aesthetic outcome that they want. Using smaller implants with beautiful projection that these implants offer, I think is a game changer. So I've been so happy with it, and I think it's made prepectoral aesthetic surgery even easier with more predictable outcomes.
Yeah, and I think it's important for the people who might just be joining who are confused by what does this breast preservation really mean. I think when we talk about breast preservation 1.0, we're talking about putting implants on top of the muscle, whether that's in the subfascial position or whether that's in the subglandular position, basically pre-PEC. And so preservation 1.0 was about not disrupting the muscle and lifting the muscle off of the chest wall. Now, there are lots of patients out there that have dual plane augmentations under the muscle, and they're not having problems with that. So it's not like we want to trash that operation and say that that operation is bad for everyone, but no single operation is the best answer for every patient. And I think we're just exploring other ways and other techniques that we can do breast enhancement without disrupting the chest wall in patients where that won't be a good idea.
And when you think about it, Ashley, back in the old days, all the augmentations were done subglandularly. The problem with it was they had very poor technique. They didn't know anything about antimicrobial, no touch, and the implants were mostly saline with high capsular contracture rates. And so now that we've have the opportunity of really understanding biofilm and how capsular contracture forms, and have better implants and tools and scaffoldings, we can really give beautiful, long-lasting, soft outcomes without all the previous worries. So it's not like, just like you said, it's not to say that dual plane is a bad operation. It's not. Dual plane is amazing for the right person, but now we just happen to have the luxury of being able to safely not cut the muscle and have beautiful, long-lasting outcomes. It's like a home run.
And I think so much of this is about being able to serve more patients. And I think that the technology that we have now with Motiva, the technology that we're going to talk about today with minimally invasive breast enhancement, it really is about serving more people and more patients. And so why don't we jump into it? Because we are now, less than a month away from minimally invasive breast enhancement in the United States. And we were just in Costa Rica, all three of us, and we were able to perform live surgery. We actually did the surgery on patients. And so we were able to see those patients, plan the operations, do the operations, and then we're lucky enough to see post-op.
Yeah.
So why don't you guys talk a little bit about what your initial, what did it seem like when you were going in? Because we all knew what we were going to do, but what was it like going in, and then how is it now on the other side?
Steve?
Okay, well, first of all, Ashley and I happen to have been paired together on the same patient. So
That's
she
great.
had the patient.
They understood the assignment.
That's right. She had the patient's right side. I had the left side, being the southpaw. Um, we were also lucky that we had a full day to watch other people go before us. So we kind of found what works, what doesn't work. Personally, you walk into this unbelievable amphitheater operating room with, people watching in the balconies through the glass, just like on TV. And it's really impressive. I mean, what Establishment Lab has created in Costa Rica is absolutely mind blowing. So you walk into this gorgeous OR, state of the art, and we had previously marked the patient with Dr. Chacon, who really taught us everything. And we none of us would even be standing here talking about this without Dr. Manuel Chacon, who really established this, pioneered this, and studied it, and has continues to do case after case, and with absolutely incredible outcomes. But I think it's a new technique, and like anyone else, you're always a little nervous. You're always even though we are all experienced, veteran surgeons, you're still nervous doing something for the very first time. Um, from the tumescence under ultrasound guidance, which we'll talk about, to creating the pocket gently and bluntly, to putting the final implant in. It's very similar to an augmentation, but at the same time, it's very different. It's a completely different operation, high level knowledge required, high technical skill required. But man, once you get the hang of it, this is going to be an absolute game changer.
Yeah, at first I was a little suspicious, like, would we really be able to do this under just sedation, like a
Mhm.
colonoscopy? Was the patient going to be comfortable? And it was so interesting that, at the end they were lifting their arms. One of the surgeons brought one of his nurses to do the case, and she was actually having drinks with us that night. And no, patients don't drink after surgery, but out to dinner with us, and, had minimal pain and was just taking Tylenol. So I think that was one piece. And then the other piece that was impressive to me is the way that we're going to use AI and technology to really help in planning this operation. And the reason we're calling it breast enhancement is because we don't want patients to get confused with like traditional augmentation. The
Mhm.
language that we're going to use when we talk about this, the volumes that we're going to use are going to seem surprisingly small to patients to achieve like similar outcomes. So I think like the whole conversation and the language we use is changing, which I'm so happy that we're going to get away from like CCs and patients being so stressed about the volume of the implant. When at the end of the day, that doesn't matter. What matters is what it looks like. What does your result look like? Are you happy when you're in your clothes, when you're naked, when you're in a bathing suit? Just like the bra size, like that doesn't matter. And so I love that this is proof of concept that we are moving away from that language.
I mean, don't you guys agree that we're really performing like customized procedures for our patients, like truly customizable, from the planning, the ultrasound guidance, that using three-dimensional imaging up front to figure it out, to really figure out what this patient's end breast volume is going to be, as opposed to just like Ashley said, oh, I want to be a double D or a triple D or a C. We're really customizing. I kind of equate it to going in and buying a custom suit. You go to the store, they measure you, they take all these measurements, and they really come up with this really bespoke plan for making your suit. And I feel like this breast enhancement, minimally invasive, is the same thing. What do you guys think?
Well,
Yeah, I was gonna, oh, go ahead, Troy. I was going to ask Troy about like when Renee said less is more. I thought that really was like, what a great tagline. So can you like speak to that and like, what does that mean? Less is more.
yeah, I mean, I think that we do, even as the surgeons, we have to reconcile in our head about planning, because really when you're planning this operation, you're marking the patient, it's very, very different than the traditional breast augmentation. And, for just to back up for a second, we're talking about minimally invasive breast enhancement, which is truly something that we can do now, but it's all because of technology. All of us have become very comfortable with ultrasound of the breast. We've become very comfortable using different implants, and we're all becoming very comfortable with AI imaging. But I think all three of those things, as both of you touched on, those are really important to this. I think you need all of that technology to make this operation work. Um, but the reason that we're talking about less and smaller implants is rather than making a pocket underneath the breast, lifting the breast, and putting an implant in underneath the breast, which is inherently unstable, we're actually
Stuffing.
stuffing, we're actually going in, we're creating a small tunnel, and then there's a surgical balloon. So the balloon goes in and actually expands the space. So the ligamentous structures that are in the middle, that are laterally, we're not disrupting any of that. So we're creating, as Dr. Chacon puts it, a little nest for the implant to go in. But what we're doing with that nest is all of the breast tissue that's surrounding the breast. And a lot of patients that we see, they've got a little bit of outer breast.
Uh-oh. Is he frozen?
Uh-oh. He's
Okay.
frozen.
It
There he
said
is.
I was using my hands too much. Um, thanks. So basically, we're recruiting that breast tissue. So using a 180 cc implant, that's really the core of the enhancement, and we're recruiting that breast tissue. So I think for me, I've only been offering this to patients for the last 5 days, but patients who are coming in and we're measuring and we're talking to them about their 180 cc implant, and they've gone to other physicians who told them they needed a 350. It's a very different concept. And so a lot of what we're going to do is we're going to educate patients about why this is less and we can do more with less. Wouldn't you agree?
And absolutely, Troy. And think of the repercussions, the positive repercussions of lower volume implants. We're going to be talking about far less reoperations, malpositions, you know, problems with implants because there's just simply less weight. Patients are going to be more comfortable. They're not going to feel so top heavy. And I tell you, I think we're going to really see a change in how implants are being used. Not only that, but with this technique, I think, would you guys agree, it's really the first time that we're targeting a specific location on the breast that actually lacks the volume. So when we preoperatively evaluate these patients, we really see where the volume is and where the volume isn't. And this procedure is really geared towards selectively targeting a specific area on their breast that needs volume to make the whole breast volume larger as a whole, but naturally and proportionately without disrupting any tissues. I mean, when you think about it, this is so foreign to us, but now that we've seen it, we're believers, right, guys?
It's customizable.
Yeah. Because how many women, I mean, I see these women every Tuesday in my clinic that come in that have breastfed, maybe one or two children. They still look really good. They have a nice shape on the bottom, but all of their volume is on the top. And they have this like skateboard ramp appearance at the top, this concavity. And they say, I have this gap in my bra. I don't really want to be bigger. I just want more volume here. And in the past, we've had to say, well, you're going to be bigger because we have to use an implant that's going to be tall enough, because obviously now we're all using round implants since no one's using texture. So the implant is round, so it's width times height. And in order to get the height to fill the upper pole where it's missing, you need an implant that's fairly wide that has a decent amount of volume. So because of that, they are going to be bigger, which is not necessarily what they want. And so with this very customizable kind of direction where we can put this balloon and expand this space, we can put that volume exactly where we want it. And because of the viscoelastic nature of these implants, they move with the patient and they feel really like breast tissue. So it's not like the patient's going to feel, oh, I have this implant in the upper middle part of my breast, and then I have this breast tissue on the bottom, and this feels like two totally different things. This
And
implant is going to be nested within their tissue.
And think about how many patients come back to you guys and they say, "Hey, why do I feel the implant down here?" And you can feel the little ripples of the implant inferiorly for when for those that don't use mesh. Nowadays, we're not going to be able to do that, and you can't feel these implants, which is so nice. It feels so natural. It moves with the breast, just like Ashley said. They look like real breasts. I mean, it's unbelievable how good these look.
And one of the things that we haven't even touched on yet that makes this so attractive to a lot of patients is because we're not really cutting, we're not using cautery, we're not using our traditional tools to do this operation. It can be done with the patient under local with minimal sedation. We can do this completely without the use of narcotics, which I think is a total game changer. Do you feel like I know that in my practice, I have a ton of young moms who there's this belief amongst all patients that when they undergo general anesthesia, they kind of die, and then the anesthesiologist brings them back to life like magic.
Right.
And so there is a real fear, just like there's a fear of flying, there's a real fear of anesthesia. So in my practice, being able to do this where the patient sits up at the end of the operation and can put her arms above her head it's going to speak to so many more patients.
For sure. And they're going to be able to exercise faster. I've told patients, I mean, I believe depending on what your job is, like you can go to work the next day. I probably don't want you picking up your children for a week or two, just depending on their size and their weight. And we are going to learn these things like as we go. I'm sure we're going to be a little more conservative in the beginning, like please don't go and do CrossFit on post-op day 2. But we're going to learn from our patients. I mean, I was impressed with the very little bruising that the patients had on post-op day 1, very little swelling. And really it was bloodless. Like, I don't feel like for the blunt dissection, I mean, I didn't see really any blood like dripping out of the incision.
Right.
So that was really cool. And I think that's because, we inject that tumescent that not only makes them numb, but for people listening, it also has epinephrine, which constricts the blood vessels. So that minimizes bruising and bleeding. And so we inject that medication under ultrasound guidance, and then we actually wait 10 minutes, which is very challenging for surgeons to do, but very important for, intra-op and recovery.
And the other thing that is so amazing and important is, the 3-year data that came out from, the European experience of their minimally invasive technique. I mean, 0 capsular contractures, 0 hematoma, 0 malposition. I mean, these results are unbelievable and are equal or better to our current situation here in the United States with our results. So from a safety standpoint, from a patient comfort standpoint, from an ease to do standpoint, no general anesthesia, and then what about the whole like guilt? A lot of patients feel guilty. Oh my gosh, I shouldn't be doing this. It's very similar to going in and having a procedure, almost having some fat grafting or fillers. It's really a minimally invasive procedure. So I think a lot of people who previously didn't want to have surgery because of feeling guilty about it or feeling scared about it, I think this is going to open up a whole lot of new doors.
And we're talking about 35 minutes.
Yep.
And I think it is basically, I was describing this to my mother on the phone this morning, and she said, "Oh, it's like going and getting your nails done." And I was like,
Well,
it's a little bit more complicated than that, but it probably takes the same amount of time.
I would say it's like a colonoscopy without the prep.
Yes.
You
Yes.
Yeah.
know, you have a colonoscopy, it's like 20 minutes, you wake up, you had propofol, feels great, you're not groggy, you don't have nausea, you go home and like go about your day. So also for people listening, this is only available with the ergonomic implant, so not with Motiva's round. The round implant is a little bit firmer because the gel inside is a little bit more viscous and less elastic. So with the ergonomic implant, the gel is more elastic, and so we're able to put it through this very narrow tunnel that we've created. Because again, it's like minimal dissection. So if you're someone that is an A cup and you want to be a double D cup, you're probably still going to want the round. You're going to have a traditional preservation 1.0 breast augmentation. And then I know, no one knows when Ergo 2 is coming out, which is going to be even more elastic, and we're going to be able to do things even with smaller incisions. And hopefully that will be next year. Again, that's not from the company because no one will tell us anything. But we're all hoping.
And this is
Yeah.
all done through a 2 to 3 centimeter incision. So depending on the size of the implant, a 2 centimeter incision is tiny, which is why we need those more viscoelastic implants that can go through a tiny aperture and then regain their shape effectively.
Yep. So then that's part of just when people ask me, like, what do you think is the most important or what separates Motiva from the other implants? And I always say, for the last 20 years since I've been in practice, like nothing has really changed. It was like good enough, and that was good enough. And that's not good enough. Like Motiva really came in and they changed the surface of the implant, the gel that's in the implant, how the gel in the implant performs. They're filled to 100%. And then, came out with these tools for us to use to, again, give patients an easier recovery, better outcomes, less complications. So I don't think it's just one thing. It's just like a mindset. I always compare, Apple to Motiva, and they kind of came in when all the other companies are like PCs, like Dell and HP. And Apple not only is like was the sexy new thing, but Apple really changed the way that we interact with technology. And I think Motiva is really changing the way that surgeons interact and talk about breast augmentation.
For
And
sure.
and I think also, just the way that they look at things, they're looking at, women's healthcare as a whole, not just breast augmentation, but how does this fit into all of women's healthcare? How are women going to be healthier and safer and less invasively? All these things, we haven't really thought about these types of concepts. And when you think about it, it makes a whole lot of sense. And if I was a woman, why wouldn't I want something that's going to be better for my overall lifestyle as a whole, maybe with less reoperation, carrying less weight around, all that stuff? But the other thing I think that we also have to talk about is, unfortunately, at least today in 2025, not everyone is going to be a candidate for this particular procedure that we're discussing. And I think we're going to have to, and maybe that's going to change over time, but I don't know about how you guys feel about it. But for this procedure, where we're creating that nest within the confines of the breast tissue on the inside of that circummammary ligament, you need to have a decent amount of breast tissue, or at least some breast tissue, for this to work. I think that the double A cup, very flat chested patient is probably, at least today, at least in my hands, not going to be a great candidate for this procedure, and might be a better candidate for the traditional, preservation 1.0 pre-pectoral augmentation with or without support. Do you guys agree with that? That you kind of have to have some breast tissue for this to be a successful outcome?
I think it's a little bit of a different, in my mind, someone who has no breast tissue, um, we're going to have a conversation about whether we're going to really put the implant in front of the muscle to begin with. So, I mean, if we have patients who have nothing and they're very, very flat, you can see their ribs through their chest wall, that's going to be someone who I'm going to talk about putting it partially or completely under the muscle. But I guess, Steve, if it was a patient who had a little bit of breast tissue, I would go with a little bit of a larger implant, maybe a little bit wider, um, because I feel like if they're a candidate for doing it in front of the muscle, I don't know that there are many people that it's not appropriate to do it minimally invasive unless they have some other contraindication. What do you think, Ashley?
Or for the patient who really, comes in and says, I really love like that round, full look at the top, and I want to look like that when I'm naked. Then I think obviously Preservation 1.0 with a Motiva round is a great option for the patient that desires that look. This, I think, is for the patient who really truly does want a more natural look, or what I call the mystery look. They want to look great, but they don't really want anyone to know. But if people kind of question it, they're okay with that. Which I think is probably, half to maybe like 2/3 of my patients. But again, I think it's just being able to offer just another option, and not just say like, okay, like this is the menu today and we only have this. Like, this is like a tasting menu. Like, we have all the things now.
So
Yeah.
someone just wrote a question here. She said, sorry, I missed it. If you want a rounds Motiva, what can't be done? And what we're saying is this minimally invasive technique really you benefit from having the ergonomics implant because we can get it in through a smaller incision. The round implants are just not compressible enough to go through the tiny incision. So that's someone who we would then, as Ashley just said, if you wanted that round look, we may make the incision a little bit bigger and do that operation in a little bit more of a traditional way.
Right. And then I got a lot of questions yesterday about revisions, like, can we use this in revisions? And I think at this time, probably not, because basically you need a virgin breast to be able to do this. Because again, it's like minimal dissection. So if someone has a pocket that's already been dissected and the tissue has already been released, then it's sort of defeating the purpose of this nesting procedure and this trying to preserve the ligaments when they've already been cut.
The cool part is, guys, is that this technique, this preservation breast enhancement that we're talking about now, this minimally invasive ultrasound guided technique, can be done either as strictly as breast enhancement by itself.
Oh, I
Uh-oh.
wait.
Steve just lost the volume.
I guess I was using my hands too much. Sorry.
Oh,
Yeah,
Um,
they really don't like that.
They don't like hands.
so
We gotta like,
funny.
and we're all very animated, so we gotta like lock our hands down. But this technique can be done as a breast enhancement alone. It can be done as a hybrid procedure with fat grafting, or it can be done in conjunction with a breast lift or mastopexy, as we saw Renee and Brad do a beautiful case in Costa Rica. Their result was spectacular with a mastopexy. So, this is really an awesome tool that I think we're gonna open it up as we get more and more comfortable with. But man, is it exciting, because man, what an unreal technique, and these results are absolutely breathtaking.
Yep. So nice for the mastopexy aug who, we always talk about addition, subtraction, and I think we've gotten really good at that. Except for the patient that comes in and maybe, they have a lot of skin, everything is on the bottom, and maybe they're like a D cup and they need a lift and they love the look of like the fullness at the top. They're like, I want to be smaller. And so like sometimes it's hard to reduce them enough while adding the volume of a traditional implant to really get to net negative volume. And I think with this, like we will be able to do that because again, smaller implants achieving kind of the same result without needing all that volume at the bottom, and then being able to recruit what they already have and like reshaping it to
And
just give
select
them a lighter breast.
and selectively placing that implant in that supromedial, you know, that's something we've never been able to do. We always kind of build the breast from the inframammary fold up. The implant
Yep.
sits at the fold. Now we're having implants that sometimes are several centimeters above the fold, where you can't even feel it from the lower pole. So I talk about, upper pole fullness long term with these beautiful Motiva implants, maybe some fat grafting. I think the results are going to be absolutely amazing.
And for those of you that are joining us, if you have questions, we are watching and we are answering questions. So if you have any, please feel free to write those in and we'll address those. So let's talk for a second about who, as we have patients that are hearing about this and learning about this. I think that, everybody wants to have the most minimal thing that they can.
Mhm.
Who would you say is absolutely someone who you would say you're not, even before you saw them, you're not a candidate?
Someone that has had multiple revisions, multiple, episodes of capsular contracture. I mean, that's just going to need a more advanced operation with obviously probably everything that we would try to preserve has already been destroyed. And so this wouldn't be a good choice for that.
And for me, it's really that super flat-chested patient. I still do prepectoral in very, very thin patients. However, I think for this specific technique, I think it requires some parenchyma in order to create that nest and elongate the tissues. I feel like if it's too small chested of a patient, we're going to see like this ball in the middle of the chest without that beautiful cleavage and upper pole. Maybe I'm wrong, but that's how I understand it. I really do feel that you need some parenchyma immediately to create that fullness. Otherwise, I think we're just going to see this kind of ball in the middle of the chest.
Can you fat graft around that? Would you consider really kind of doing that hybrid breast augmentation?
Absolutely, but those are going to be alloclay may come into play with those cases, because obviously those are going to be the patients that are going to have limited donor site.
Yep.
But absolutely, the hybrid is fantastic, and it would be great. Um, and then the question is, do you do that with the minimally invasive and then fat graft later, which is totally reasonable, or do you just do the standard 1.0 prepectoral aug, which you know is going to be a home run no matter what. So I think more than one way to skin a cat, and I think that's the beauty of what we do is, we all can find ways to do things and come out with equally beautiful results. Maybe, more than one way to skin a cat, which is pretty awesome.
Where did that start? Skinning cats.
I don't know.
Yeah. What is the etymology of
That's a
that
great
state?
question. That's a
If someone
great
out there is
question.
smarter than us, please
I
write
don't
it in
know.
there. I want to know.
Please let us
Um,
know. But I
we
think we've
do.
all been focused on minimally invasive, right? We've been focused on smaller incisions, less dissection. We all do like these protocols to minimize narcotics in the office. So I think, while this is something new, the concepts behind it and the way that we've been practicing medicine and surgery, I mean, it's just very in line with what we've been doing. We just now have different tools in order to do that. And I think in a couple of years, when Ergo 2 comes out, which again is more elastic, we're going to be able to use bigger volume implants for those patients that do want to be larger using these less, invasive techniques. So lots of things kind of on the horizon as well.
One of our viewers has written in and is asking, is the minimally invasive incision under the breast or in the axilla? And
Oh,
so this
yeah.
is, go ahead, Ashley.
Yeah, in the crease.
Yeah, in the crease where it hides in the crease. We're not doing this one through the axilla. Steve, someone wrote in saying, so no need for internal bra with this technique.
Great
Question
question.
mark.
I have been thinking about that question time and time again because, as you know, I use mesh and I use a lot of it. Um, I think particularly with small volume implants, 150, 170, 180, I would say it's probably not necessary. If we start increasing volume and weight, I still feel much more comfortable supporting these implants with the scaffolding at the lower pole because I think no matter what, everything is going to stretch, tissue stretch, gravity wins in the end. And what is the cutoff? Is it 250? Is it 300? Is it 350? I think we'll find that out. But for me, small implants, I do feel comfortable with no mesh. Big implants, I'm probably still going to at least offer it and talk about the whys. Obviously, it's an increased cost, but you're also paying for potential long-term stability. We'll see how that goes, but in my book, I'm still a believer of scaffolding and lower pole support, particularly in the upper registers of the implants.
And
Yeah,
I
I don't know how we're gonna get that mesh in there, like the scaffold, like
Oh, I
just
got it.
like
I'll show you. I'll show you.
the
I
two
got it.
centimeter, in the tissue for the tunneler. I mean, I'm sure you've been thinking about it, but I'm hoping to disagree that this is going to allow us to not use scaffold, which I still love, but if we don't need it.
Steve, I have a question that someone from another forum had asked was one of the things that's really nice about Motiva's smooth silk surface is that it is anti-inflammatory. It doesn't create any type of inflammation. Is there a scenario where putting mesh in against the implant, is it counterproductive to using a biocompatible implant because now you're placing something in there that is inflammatory?
Well, I think in reality, you're almost doubling the capability of anti-inflammatory. One of the things about P4HB is that as the P4HB gets resorbed by the body's immune system, there's actually upregulation of two peptides in the body. One of them is anti-inflammatory and the other is antimicrobial. So I do feel that it's actually reducing inflammation, which is why I use it for my capsular contracture repairs all the time and get great results, minimal recurrence because of this anti-inflammatory. So the Motiva implant plus P4HB in my world equals way less inflammation, which equals way less biofilm, and which equals way less capsular contracture.
Yeah, I
Okay.
agree with that.
All right. What about we've talked about this. What are your feelings about using a different implant with this technique?
Absolutely not.
Yeah.
there is no other implant on the market that has these viscoelastic properties. And so just like we see all of the time with people trying to do crazy things and save money, there are going to be people who are going to try to use those old dissectors that people use when they were trying to place implants through the belly button. Yes, that was a thing for a while. They're going to try to use expanders and balloons to try to, not pay for this kit. And we all know that that's just not going to work. You have to use this implant with this technique because conceptually, like they were designed together to be compatible. So I'm sure we're going to see people try, but the dissections are going to be much more aggressive.
And
And I
it's
think
something
you're
that,
go ahead,
sorry,
Troy.
Steve,
No, go.
I was asking a different question, so you keep going.
I think with those other implants, you're going to see a list of problems because it's just not the same thing. It doesn't have the same surface. It doesn't have the same, cohesivity, viscoelasticity. They're going to not be able to, they're going to be breaking them, trying to get them through that tunnel. It's just simply not going to work.
What I was going to mention was, Motiva and Establishment Labs, the parent company, they're very, very committed to surgeon education, and they're even more committed to providing these instruments and implants to board certified plastic surgeons only. And so, if you're going to someone who has procured the tools to do this operation correctly and they're using Motiva implants, rest assured they are board certified plastic surgeons. I do think that we live in a world where everyone's going to try to create their own. And so it's important to ask those questions and make sure that are you using Motiva? Are you using the Motiva minimally invasive instruments? Those are all really important questions.
And I think for safety, while it's always this way, right? When things seem like so easy, I think that's when surgeons who haven't been appropriately trained can get into trouble. So I would
For sure.
also ask, or when you're in your consultation, like, are they using this 3D imaging to really look at this breast topography and really evaluate total breast volume? Can you see what that implant is going to look like in the simulation? So have they invested the time and the money into having that software and learning how to educate you with that? The other thing is, are they proficient in ultrasound of the breast? Because we have to use local anesthesia. We need to make sure we're in the right plane because we're making the patients numb with the anesthetic, but then we're also kind of hydrodissecting that pocket. And so, especially in a really thin person, like those layers are not very thick. And so with ultrasound guidance, you really know that you're in the right place and safely injecting that medication. And then also after you use the dissector, making sure that you're again in that right pocket, that you're not in the muscle, that you haven't, gone somewhere where you don't want to be. Also that you're not too superficial. So while, Manuel can do it in 10 minutes and makes it look like, we're walking in the park and there's unicorns everywhere. I think it's like anything else. Like people who are really good make things look easy. And those people, are always thinking about what could go wrong and being just very proactive about safety.
I think that Ashley is 1000% accurate. Even though this seems like a chip shot, like, oh my gosh, anybody could do this. It's so easy. I feel almost that I almost feel like it's harder technically to do this procedure because it's so specific and it's so planned and the precision required to just the markings. Where's this implant going to go? Where's my tunnel going to be? Just that I think is quite complex and it's certainly not an easy procedure. I think once we master it, it's going to be, we'll do this really quickly. But, I would very strongly recommend that people don't consider this just like a blow off procedure. Oh, just quick, easy, no big deal. I think a lot of people could potentially get into trouble that way. And I think the complication risk with pneumothorax, all those things are very, very real. And if you're not adept at ultrasound use and using ultrasound to infiltrate and being exactly precise with your techniques and your tools, I think you could run into a lot of problems.
100%. We have a question. Have you seen any downsides or negatives to placing the ergonomics implants in the subfascial position? So implant movement, rippling, things like that.
You want to answer
Not
that
at
one?
all. Yeah,
I
I
have
mean,
not had a
I
problem.
I've
yeah,
had two patients who had ergos that have a little bit of visibility. And so we've talked about doing alloclay in those patients. Just the patient that's really, really thin. You can see their ribs underneath their skin. So it's not really like a rippling issue. It's more of like you can kind of see that
And,
implant, especially when they lean over. And I think the rounds do that a little bit less. But again, not everybody kind of wants that look.
yeah, it's a tough balancing act that we have to kind of navigate when someone is super thin, doesn't have a lot of soft tissues, but at the same time they want the ergo implant, which, is such a beautiful implant for these, ballerina yoga style breasts. I agree with Ashley. I still use it all the time in super, super low BMI patients. I think the rippling is minimal at best.
Mhm.
And the beauty of having aloclay nowadays is that you can always touch it up if you need it. I've been really lucky. I've been doing this exact surgery for many, many years, and I've not seen a lot of rippling. I think patient selection is key, but I do think that these implants have been a game changer regarding visibility, palpability, and rippling and wrinkling, particularly in low BMI patients.
Yeah,
and
my,
from a technical standpoint, when we see superior medial rippling, so many times that is from lack of support
yeah.
in the bottom of the breast, particularly laterally. So when we see rippling in thin women, a lot of times those implants have kind of moved around in that pocket, and that lack of support from the bottom causes the top to ripple. With this technique, we're actually, with this nesting concept, we're supporting that implant. You can really feel in that pocket that there's a lot of that supportive tissue there. And so I think with more support, we'll paradoxically see less rippling.
Yeah, that's absolutely right, Troy. And we're not cutting through the structures that actually provide the support. We're not blowing through the fold. We're not blowing through the ligament. We're preserving all those natural barriers of the breast. And I love how Manuel says it. They call it elongation of the
Mhm.
tissues. That really makes sense, and it really strikes home. You're elongating that space. You're not cutting it, you're not traumatizing it, you're not pulverizing it, you're just stretching it out, creating room for these smaller implants. So when you think about it, man, does it make sense?
Yeah, I also wanted to touch on for patients to know. I think we're all three of us are really big fans of sizers. I think all of us use differential implant sizes a lot because obviously patients have volume asymmetry, chest wall asymmetry, scoliosis, whatever the case may be. So the other reason why it's very important to it's not just an easy operation is because we are not using sizers in this operation. Everything is being planned beforehand. And it's probably the only time I'm going to go to the operating room with two boxes. I'm going
Yep.
to,
Oh, Ashley,
Moving too much. Where's her volume?
she's
now?
there you
Yeah,
go.
now. There you
Okay.
go.
We are going to know exactly what implant we're going to place before we get into the operating room. Because with this balloon dissector, if you were to put a sizer in and then you're like, oh, I want to move it a little bit more this way or that way, that again is just making that pocket larger. And so that negates the whole reason why we're doing this technique. So it needs to be placed perfectly and precisely the first time because there is no second chance.
Jolene's asking, is it true we're starting to offer this to our patients in August? And that is absolutely true. So mid-August is when we will start doing our first cases in the US.
Yep.
Exciting. Exciting.
Very exciting. Okay,
Exciting.
so we've got a little bit of time left. Any final thoughts? This is the time to write in your questions. If you have questions, Anything else that we haven't covered that you feel like is important for people to know, particularly about this technique?
I just want to say it again. Let's start talking about total breast volume. Let's start talking about where we want the volume, and let's stop talking about cup size and CCs and cohesivity. All of the implants are cohesive now. Let's talk about different elasticities of the gel. And in the future, we're going to be talking about super silicones, which is kind of the next iteration of all of this. So let's all start using this language so that the patients understand what we're talking about.
Yeah, we're not talking
So,
about gummy bear
No,
implants anymore.
no,
exactly.
That doesn't make sense.
No more gummy bear talk. No
no.
more gummy
That's
bear
old
talk.
news.
The answer is yes, they're all gummies. They're all
Yeah.
gummy.
Okay, well, thank you guys for Steve and Ashley. Thanks for spending your part of your morning. It's like almost dinner time in DC, but
Oh, yeah, it's lunchtime here.
thank you for joining us. For everyone who is watching, we're going to post this on our Instagram pages, so you can invite your friends to watch this if you're just joining late. And here comes the future of breast surgery.
And
Get
let us
ready.
know. We're thinking about doing this maybe like once a month, just different
Yeah.
topics on breast surgery and kind of plastic surgery in general.
Yeah.
I think there's a lot of podcasts out there, so we don't want to do that. But this is kind of fun, and so we might be doing this. So let us know if you'd be interested in that.
It's called
Great.
GPS, Gordon Pittman Sigalove,
There you
GPS.
go.
Yes,
There you go. I
love
love
it.
it. Love it.
All right.
All right, love
Have
you
a good
guys.
day. Have a
Thank
great
you.
weekend.
Bye.
See ya.